SBRT and SRS clinical aspects and radiobiology, focusing on the things that we think are most important for you to know. And I'm accompanied by my colleague, Dr. Ryan Jones, who will be leading the talk about the radiobiology. So to begin, what is SRS and SBRT or SRT and these other acronyms that we see? These are all techniques to deliver high doses of radiation per fraction. Conventionally, we usually think of giving radiation in 2 gray per fraction or 1.8 gray per fraction, but we will begin to see with these techniques, we can deliver doses of 5 gray per fraction or more. SRS stands for stereotactic radiosurgery. This is treatment in the skull in a single fraction. SRT is stereotactic radiotherapy, which is treatment in the skull in multiple fractions, usually 3 fractions or 5 fractions. Oh, sorry about that. Please be careful not to share screen. And SBRT stands for stereotactic body radiotherapy. This is also known as SABR, or stereotactic ablative radiotherapy. So when you see SBRT and SABR for this course, we'll consider those the same things. And this can be treatment in a single fraction, like SRS. It can be treatment in multiple fractions, like SRT, but it occurs outside the brain. So the spine or the liver or the lung, and you'll see different examples throughout this course. What do some of these treatments look like? Here's an example of a metastatic disease that was treated with a stereotactic treatment. This was before, and this is after. And so this gives a treatment at a very high dose, sometimes between 12 and 70 gray in 1 fraction, prescribed in a different way to a very focal area. Similarly, for stereotactic body radiotherapy, we also have high doses in few fractions. Commonly in the US, it's 1 to 5 fractions, because that is how we bill the insurance companies. But really, any treatment that is high dose per fraction can be considered as SBRT. So in Europe and some other countries, they might use 70 gray in 10 fractions. And what are some things that we're seeing? Well, we're seeing new ways of prescribing treatments, prescribing to the 50% isodose line or 80% isodose line. We're seeing new ways of treatment planning. Now we're allowing hotspots inside our target of 120% or 150%. And, this is very unconventional. This is new. And we're able to use these treatments not only to treat tumors, but even to treat functional medical conditions like trigeminal neuralgia. And we have new options for treatment. Shown here is a SBRT of the spine. And you see we're not including the whole vertebral body. We're just including part of it. So it's very interesting. And we will see that there's new special delivery mechanisms. We have enhanced immobilization, even motion tracking. This is a picture of someone who's getting treated for a lung tumor, and we can track their breathing up and down. We have new considerations for our calculations by our physics team and new techniques for treatment planning. And this is what a treatment plan might look like. This is showing someone's spine in the axial view. And you can see how sharp the dose fall off is. The target is getting hot dose, but the spinal cord is getting very, very little dose. And so this takes a lot of work to achieve. And you have to be very, very careful and accurate about positioning and dose delivery, because you don't want this hot dose to fall down and end up on the spinal cord. How do we achieve such accuracy? Well, a lot of times we actually will begin using outside imaging more frequently. This means bringing in MRI scans, bringing in PET scans, and merging these with our CT simulation scan. And this is a common example with prostate, that we have the CT simulation scan. We also will import their MRI scan that they had, and then we'll overlap them and try to line them up perfectly. And for SBRT of the prostate, one of the things that we are very careful about is avoiding hot dose to the urethra, which goes through the center of the prostate. And here you can see that if your alignment, if your fusion and registration is off, what looks like the urethra on the MRI actually might not be the urethra on the CT scan, because that registration was not done perfectly. So we will talk much more about this, but the implication is if you give hot dose just outside the urethra and you think, oh, thank goodness, I'm sparing the urethra, you might actually be putting the dose exactly in the urethra. And now the patient is going to have trouble urinating for the rest of their life. So this is a team effort, and we have to prevent this from happening. We're dealing with very powerful radiation, and we want to make sure we're not missing the target and accidentally hitting an OAR. Why is this so important? With a very high dose of radiation, it's kind of like with great power comes great responsibility. And the way that we draw the targets, we're very, very tight, very, very picky. And so there's not a lot of room for error. And if you're off by a little bit, if the contouring is off, if the treatment planning is off, if the QA is off, or the patient positioning is off, the radiation oncologist, the medical physicist, the radiation therapist, it's all a big team effort to make sure we're as exact as possible so that we don't accidentally underdose the tumor and so that we don't overdose an organ at risk. Not only would this cause a lot of damage to the patient, but the patient would have a recurrence in that same area, maybe months after the treatment, and it would be very, very hard to retreat that spot. Treatment options would be limited because it got such high dose already. So, why are we even taking the risk to do such high dose treatments with a stereotactic technique? Well, let me tell you that if you can perfect this technique, it opens up a world of possibilities. There are numerous benefits for patients, for clinics, for costs, and for society, and it'll allow patients to access more treatment options. So patients who are too frail to get surgery can now have similar outcomes with SBRT or SRS. Patients who have metastatic disease now can be classified as oligometastatic or limited metastatic disease, and actually we're seeing them live for years and years in the US. This is unexplored territory, and we do have more opportunities to re-irradiate patients if we need to, because these SBRT and SRS treatments are so focal that it allows room to do radiation in other parts as long as they're separated from the original spot. So in our CNS clinic, for instance, we have patients who are coming in for SRS treatment, every couple months or years, but as long as we are very prudent, we can manage any new disease that appears. With these treatments, they are so short, 1 to 5 fractions. This is less travel time for the patient. This is less cost for them and their family. And, and this is more patients that you can treat in your clinic. So we can reduce wait times, we can reduce the cost per patient, we can improve access to care, and altogether we can enable a healthier, loving society. And with this, I'd like to pass it off to Dr. Ryan Jones. And Sarah, were there any questions in the chat?
No questions so far. Thank you very much, Ben. And I think you have the mic, Dr. Ryan, Dr. Jones.
Hey. Hi, everyone. I hope you can hear me okay. Give me a moment. I'm going to pull up the file from my slides. So to reiterate some of the things we mentioned earlier. Well, first off, I apologize. So I'm a clinical radiation oncologist, and I am here on my own today covering my clinic. I've asked my machine and my staff to please give me some privacy until after the next 45 minutes or so. If my phone rings, I apologize. They know to send me messages if it's truly urgent. We'll work through that. I want to encourage collegial open discussion. If you have a question on a certain slide, I don't mind. You can place it in the chat. Sarah is encouraged to interject. It can be a variation of a case as I go through some slides at the end with certain case types. Whatever it is, if I speak too quickly, I apologize. If I use a term you don't understand, don't hesitate to ask. We will clarify and go from there. So let me minimize this speaker view so I can see the whole slide. A little introduction about who I am, just so for context of what I'm sharing. I'm one of those, common stories of a child of a cancer patient who, since I was a kid, I devoted to being an oncologist. Thankful to get exposed to radiation oncology very early in my kind of primary postgraduate years. We call just college here in the U.S., where I started working in radiation oncology for the physics team at the University of Virginia, and worked for medical physicists for about 6 years before I went on to my training after medical school, we call residency here in the United States, where I was at the University of Texas Southwestern. Very fortunate there to be trained under Bob Timmerman and Hock Choi, two of the kind of godfathers for SBRT in its modern form. It was Timmerman pushing the envelope when he was at Indiana University of the dose escalation trials in lung cancer that really defined our understanding of, you can actually do this. It was he who dealt with being yelled at national meetings in the late 90s and early 2000s, people scared that, this wasn't safe and couldn't be possible, but they persevered. I have my own biases from my training with them and what they taught me, and probably my personal admiration for them and belief in their theories. While some of these topics are controversial, I want to mention that if I may share a story or perspective he taught me, particular Timmerman, these views are my own. I don't speak for him. I've done my own reading, settled on my own beliefs here. I may go through some case variations that will differ a little from something you'll hear on a later talk in this course, because honestly, there are multiple ways of reaching the same goal, subtle variations, and that's okay. We have our stylistic differences, like as if you asked 5 surgeons, about a surgical approach for a given cancer. My interest outside clinic has been mostly policy. Where in the US, I did a health policy fellowship, interested in impacting quality of care, regionally, nationally in the United States. Now, in the United States, if we don't go to a university, we might join a big private practice company, where I'm a member of one, which is now called One Oncology. We are about 250 oncologists. The number keeps growing, but something like 60 to 70 radiation oncologists, where I'm one of the representatives for our kind of national committee of what directions we move for radiation oncology. In the US, we have the organization ASTRO, you may have heard of, American Society for Radiation Oncology. I do some volunteer policy work for them, including their recent update on the stereotactic radiosurgery work group policies, these guidelines we put out from that organization. Learning objectives that were defined by RCC, but I want to mention here our goals, your takeaways from this talk. To be able to describe to a colleague some of the current understanding and limitations of how we believe hypofractionation behaves with respect to radiobiology. To retell some of the principles of normal tissue toxicity with these techniques and normal tissue recovery, specifically spinal cord recovery over time. We want to encourage you in uncertain situations to turn to literature, to clinical trials, to publications, to help you in complex clinical scenarios, and to be able to assess treatment decisions for spinal cord reirradiation comfortably with support of these materials and reference to others. A little overview of what I'll be sharing with you today. A little a historical primer of how we got to what we, at least in the United States, deliver, or I can't speak for the whole US, but some leading techniques of SRS and SBRT, some of the radiobiological models for SRS and SBRT, and clinical fundamentals. So the session topic was, radiobiology and clinical applications. Big topic for 45 minutes, but I thought of, if I was teaching this to someone for the first time, what key takeaways would I want them to have, in my 45 minutes I have with you? So a little historical primer. We are all very well aware of some of the benefits of fractionating, protracting radiation. You look back to the 1900s and the predominant treatment patterns when they defined in the first part of the century, hey, we can tell the normal tissue doesn't get as damaged if we drag the treatment out over many weeks. What they used their skin as the first dosimeter. There we go. There's my machine, but they should text me if I need anything. But the skin is the first dosimeter. They didn't know a lot of the radiobiological mechanisms for what they were clinically observing. But in this era of less sophisticated technology, that protraction, those many small once daily doses allowed for less normal tissue damage at the expense of some things like at times poor tumor response, as we'll go through. You may think about some of the pioneers from North America, at least, of modern radiation oncology, the Gilbert Fletchers, the Del Rogados, Larry Kunz. They were limited from what technology they had available, and that they physically could not escalate the dose to the degree that we can today with more superior technology. There are many key advances they just didn't have, whether it be stereotactic targeting. If you look at some of the evolution of gamma knife in this frame-based system for intracranial treatments, coordinates to better define where target lesions were in the body. Can you see my mouse if I move here?
Yes.
Anyone? Okay. So
Yes.
There are frame-based extracranial systems, which I trained on. Honestly, Timmerman built the original frame-based system, and we still had them at UT Southwestern when I was there. They're not sold in the US, I gather, anymore, and so most centers aren't using them. But when he in the 90s was first doing some of these, and they didn't necessarily have cone beam CT on their machines, so they were looking to use coordinates from a rigidly registered device, in this case a frame, to better or more precisely define where is their target. Our movements of our machine improved with not only how many angles we could treat from, but the way it modulated at these select angles. And then on an arc live, we developed some more understanding about non-coplanar arcs. And then, as Ben gave you some introduction to, we move on for SBRT for certain sites. There are many variations to how we secure patients now, whether it be these larger backlock systems. This one, I believe, is called the ProLock from a company called Civco. We have some tools available for monitoring the body surface of a patient. So if your immobilization device maybe isn't quite as thorough as, say, a frame, might you do something else like monitor surface of the body to make sure a patient doesn't move, to help provide some reassurance? These are key technological advances that made all of this possible. And without them, we may be likely still just on the small daily doses of protracted radiotherapy. These, as I mentioned, have been essential, but equally as important has been our improved understanding of radiation biology, because these treatments can work both ways. As been mentioned, without careful precision or consideration of normal tissue, you can have severe late toxicity, such as ulceration, denervation, fibrosis, fistula formation. In fact, why not? For something like lung, just a simple APPA field with shaped blocks. This is one from a patient treated in the 90s on one of Timmerman's dose escalation trials from the Indiana University, where they were learning on what we call in the US a phase 1 trial. Is you start at a low dose, you work your way up. We've done this for radiation, we've done this for medications like chemotherapy, and you work your way up to the maximum tolerated dose. And you learn what the body can tolerate. Otherwise, you don't really know what your true dosimetric constraints are. Patients thankfully participated in these trials and sometimes sacrificed a lot with toxicity seen here for us to learn what the body could tolerate. As I'll talk to you about later, for examples like the spinal cord, there's still limitations. We don't consider it ethical to do a dose escalation study for our spinal cord because we don't want to paralyze patients. So with that ethical piece in mind, there are limitations to what literature and data we have. A refresher, you may have seen the slides from the prior RCC course linked here, and they're available for you to look at later, where they go through some of the radiobiology of high doses of treatment. We normally talk about the 4 R's of radiobiology. That's repair of sublethal damage, repopulation of cells during radiation. We think about this a lot with, say, head and neck cancer after day 28, or with cervical cancer if total treatment course is too long. Redistribution of cells within the cell cycle. So are they in those radiosensitive M or G2 phases up front, or do they redistribute if we fractionate? Reoxygenation of surviving cells. So are there hypoxic or more radio-resistant pieces of tumors up front that may, as you treat them over several weeks, those areas become reoxygenated and more sensitized, which would be nice. And then nowadays, you might say a 5th R of the intrinsic radiosensitivity of the tissue. And if we put these into context, for a target and, I see a question, but I'll keep talking until into context for targets and normal tissues. You might say, of what we achieve through fractionation, prolonging the treatment, repair of sublethal damage, that's bad for targets, but of course good for normal tissue. Repopulation, bad targets. Redistribution can be great for us for tumors, but bad for normal tissue if they redistribute to radiosensitive phases. And the same pattern for reoxygenation. What question do we have, Sarah?
Would you like to unmute your microphone to ask a question? I think you can continue.
Yeah. If you think of it, please, we'll happily answer. So thankfully, with some of the elegant, advanced, looks like he's drawn on the screen, technology, we can now approach situations where our treatment is so precise, we're able to surpass, clinical risk based on just exposing a small volume of normal tissue to these high doses. Depends on the tissue type. We'll talk about the structure of, tissue types later. And with SBRT, we believe it's not just those 4 R's. We may even get some additional benefits, such as anti-tumor effects, from enhanced immune response or enhanced vascular injury. There's a nice review article referenced here in a journal called Radiation Research in 2012, where these authors reviewed at that time all of the studies available for vascular-related effects of stereotactic ablative treatments, SBRT. And they talk about, trials or studies that looked at, say, repeated MRI imaging during and after the course of treatment, studies that took xenografts of human tumors onto animals and then treated and studied vascular response. And so they drew out their takeaway from, kind of their systematic review, where they focus on the thought that as we reach higher doses per fraction, we reach a point where we are able to achieve an interphase cell death, regardless of what phase of the cell cycle the tissue's in. They're able to vascular supply to tumors and cause this, uniform, non-selected cell death. So they're able to overcome issues with redistribution. They're able to overcome issues with reoxygenation, where they don't need that because they're delivering such a supremely high dose. And by shortening the overall treatment package, SBRT, through getting complete in, say, 1 to 2 weeks, is able to surpass some of the issues with repopulation of cells that you may see over 6 to 7 or 8 weeks of, I call it, conventionally fractionated radiation. And you go back to in the middle of the 1900s, when they were starting to notice that, tissues vary in radio responsiveness, and and survival fractions can be plotted out in an exponential survival curve. Well, in attempts to later model, how do we represent, the response of certain tissue types to radiation across a range of doses? A common theory was that, there were these 2 key kinds of radiation damage at play here. There were single lethal hits. So there was a single electron blasting through and causing your double strand break, or there was this accumulation of sublethal damage. So maybe electrons causing just a single strand break, but if in close proximity to each other, could lead to cell death. It was modeled out that The single lethal hits were plotted linearly on the scale, and over time more related to total dose, delivered, and less sensitive to or less affected by protraction of the overall treatment course. Whereas these sublethal hits related more to a quadratic behavior with total dose, such that if you prolong the treatment course, you could allow time for that tissue to repair some of that sublethal damage and become less injured. And one of the most commonly accepted radiation biology models is called the linear quadratic model. Do you have a question? Drawn. Where I'll focus on the version. There's a version now that includes a time function called the Lee Cache time function. But more so, you'll see these plots of trying to represent for a given tissue type, how does it behave? Is it more of a total dose and a more linear behavior, such as these high alpha beta tissues that are less sensitive to fractionation? Or does it behave at higher doses in a more quadratic manner, where we may preferentially spare them by protracting or fractionating the radiation? We've plotted these out, and you can search the literature, for different tumor types. And there are different cell lines even within the cancers that demonstrate different alpha betas, for example, different cell lines of lung cancer. We normally, for simplicity, call on our formulas alpha beta of tumors 10. We know that that doesn't always apply. For example, most breast cancers are now about a 4, believed to be about a 4. Prostate cancer is about an alpha beta of 3. And we can use this to our advantage in the area of SBRT if we're able to deliver a higher dose per fraction for a low alpha beta tumor to achieve better kill. So a smaller surviving fraction of the tumor. This comes in a careful clinical interplay with normal tissue that for late toxicity, we estimate low alpha betas on the order of 3, sometimes 2, like spinal cord. When you look at this particular model, the linear quadratic model of cell kill, you can see that for low alpha beta tumors and even some for high alpha beta tumors, it estimates a supremely low surviving fraction from that quadratic tail, where it honestly overestimates the ability of these doses to kill tumors. And this overestimation can be a problem clinically. In the late 1980s, this formula was proposed. So how do you take treatment courses of different fraction number and dose per fraction and speak to them on the same scale? So how do you take 3 gray times 10 fractions for a total of 30 and put that on the same scale as 5 gray for 6 fractions? And here's one style called the biological effective dose proposed. It's in this formula, and built off of the linear quadratic model. And let me show you an example of how at high doses per fraction, this can lead to some inaccuracies. All right, so let's say we have a lung tumor where I mentioned alpha beta 10 is generally used. And we're going to deliver a treatment, high dose per fraction of SBRT to this early stage lung tumor. So this is 60 gray and 5 fractions in this example. If we estimate our biological effective dose, plug in the formula, we reach 132 gray. What would that be in 2 gray fractions? You rework, and there's something you'll see later called a equivalent dose formula, which is just them solving for N using 2 gray as the dose per fraction. But the equivalent dose formula, if we use that and solve for N, we would say, okay, that's equivalent to 55 fractions of 2 gray according to this formula. So the biological effective dose formula would say 60 gray and 5 fractions is equivalent to 110 gray and 55 fractions. But we know, truthfully, that's just not true on clinical outcomes data. And what about for organs at risk? Let's say spinal cord tolerance and alpha beta 2. If we take 40 gray and 20 fractions, we believe, we can give spinal cord 40 gray and 20 fractions, and risk of radiation myelopathy is super low. Well, we take that BED formula, find a biological effective dose of 80 gray. What would that be if we were working backwards to 5 fractions? What total dose? So you plug it in, you solve for your fractionated dose, which is 4.74, and you'd say, okay, in 5, that 40 gray and 20 fractions, according to these formulas, would be something like 23.7 gray in 5 fractions. So it suggests that while we know in fractionation 40 and 20 is very safe, that, oh yes, 23 and 5 should be very safe, when in reality, that's about the max dose that we allow, for a small volumetric area of about a half a cc, because we know it's not safe to radiate a large volume to that in 5 fractions. And so in that way, we advise caution with some of these conversions by the linear quadratic model, because tumor control, the potency may be overstated, and OAR conversion, so the safety, may be understated. It's this dangerous potential fallacy of that it is both more effective and safer than it really is. So a theme, and these are one of the objectives of limitations of some of the radiobiological models. It reaches a dose per fraction where it does overestimate cell kill. There's a debate at when this happens. Some say 10, some say 20. It inherently assumes the same effect for each fraction delivered and assumes some reoxygenation between each fraction. Other groups, like the group from UT Southwestern, took cell lines and in vitro, modeled out survival and reached a more, linear tail there at the end. This is called the universal survival model. It's just one of several. There's one called linear quadratic linear, which about matches universal survival curve, universal survival model. Key messages here are they all have flaws, but they're often our only alternatives. We need quality data. There's a phrase in the academic side in the US of garbage in, garbage out. So if it's not a well-designed trial, if it's not carefully collected data, then you're risking many errors in your takeaways and your conclusions. You have to be very careful with these studies and continue to read, because our understanding of tissue response to these treatments continues to evolve. We have a Zoom poll question.
Yes, sir, I can do this. So here's the question for the audience. Why does stereotactic ablative radiotherapy, SABR or SBRT, work so well, even if the entire treatment is only 1 to 5 fractions? Is it because as long as the biologic equivalent dose calculation matches the conventional fractionation calculation, the treatment has nearly the same effect? Is it because giving a very high dose per fraction can cause new kinds of anti-tumor effects, such as anti-tumor immune response or enhanced vascular injury, although we're still learning a lot? Is it because high dose per fraction hurts tumor cells and remarkably does not hurt healthy cells? Or is it because the efficacy of SABR SBRT is modeled and explained according to the linear quadratic model? Wonderful. We have about 90 responses, so we'll give 20 more seconds for you to consider and put in your option. Okay. Very good. We see the answers coming in. We have 180 responses now. Okay, and we'll give 6 more seconds. Put in your answer. 3, 2, 1. Okay, great. And so can everyone see the answers? And Ryan, do you want to share which one is the correct answer?
Yeah, so I can acknowledge the kind of thought process behind a few of these, but I want to address each just to drive home some of the points. The people who chose the first answer, as long as BED matches conventional MRT, the treatment has nearly the same effect. It is true that we are trying to make sure we give enough within the 5 fractions to cause a necessary tumor kill. So we're not going to sit here and deliver 4 gray times 5 fractions for 20 total and expect most tumors to die off long term. But there's more than here, because as I mentioned, over some of the cell types with, say, a low alpha beta ratio, they are more sensitive to larger doses per fraction. And they don't have the same treatment effect necessarily represented well by that BED formula. Option number 2, which we're driving home, would be the better answer. Giving a high dose per fraction causes some other antitumor effects, and we are still learning a lot. I think that is absolutely true. It is seeking to go beyond some of the issues that allow cells to regrow during conventional fractionation. It is trying to truly ablate and kill off the cells. Now, do you define even something like 5 gray times 5 for 25 gray as SBRT? The way I was trained, and my bias is no. I have seen cases sent to me for retreatment where a treatment failed in a certain center called like 25 gray and 5 fractions to spine SBRT, and they did it in a stereotactic style, or they might call it saber, but it's not ablative at that dose. So we are seeking, yes, to achieve kind of a new biological response. High doses per fraction hurt tumor cells and remarkably does not hurt nearby normal tissue. Well, unfortunately, it does hurt nearby normal tissue as well. We have to be very careful of that. So not the third answer. And efficacy modeled and explained according to linear quadratic model. That's true that it is. That's one of the models that some still to this day, you can read papers from the last couple of years saying they believe it does just fine at the doses we use clinically. They support using it, but we're seeking the better answer would be this second option.
Wonderful. So option number 2.
Oh, did I not share results?
Oh,
there
that's
it is.
good.
Okay. This is the clinical fundamentals. Okay. You may have heard of this American Association of Physicists in Medicine. This is AAPM TG Task Group 101 paper, which listed some of the dosimetric constraints. And I think it was like 2009 or 2011. This was a start, but our normal tissue dosimetric constraints continue to evolve. Many of the numbers have changed. That's a key takeaway. Here's the kind of reference for that paper. I worked under Stan Benedict. He was actually the head of physics at UVA when I was there and came on board, or left a few years in, but he's at, I think, UC Davis now. Here's a newer one that I like very much that you may have access to, or we can maybe get you access. A group from Canada went through some of the active clinical trials and listed constraints being used in those clinical trials, published in a journal called Practical Radiation Oncology this year. And they have these tables, which I will not try and go through all of this right now, but I wanted you to have it in the material, listing out some of the constraints that we'll hear for our different tissue types, because some of these I mentioned have changed from TG 101. And you should always, as you do, I'm sure, even for your conventional fractionation cases, be sure to check all organs at risk nearby to try to meet these limits as much as you can. Our tumor control probability estimates continue to evolve, particularly in the metastatic population. And so follow some of the literature there. I saw cases where at Southwestern, by the time I came, thanks to improving systemic therapy, we now have metastatic patients living much longer than we ever did before. And we would have patients out, 10 to 15 years from their metastatic disease diagnosis. But it was very enlightening how you might take something like 24 gray and 1 fraction to a spinal met, which I'm not pushing you use as your standard dose, but it's often used, or say 20 gray and 1 fraction to a vertebral metastasis or an intracranial metastasis. We use these doses, and from some of the older trials, we thought, yeah, they work pretty well, local control 90+%, but the patients weren't living very long. And as these patients live longer, we are being humbled that some of these regimens aren't as effective long-term as we thought they once were. And so keep an eye out for some of our understanding of how do they each work as these patients live longer. Something we're not going to talk about much in this session, but it's something to be aware of, I'd say, watch out for in the literature, is that we may provide benefits as a field, for these patients called oligometastatic, with a limited number of metastatic spots at either initial or later diagnosis. or oligoprogressive. We know tumors mutate in each. You can resect, 5 metastatic sites and they'll have different genetics. And it may be that we are providing benefit to more oligoprogressive patients in the future with something like SBRT, just requiring only a few treatments for these patients at a potent dose. Ablative imparts higher risk, and patients can get hurt if mistakes are made. This requires extremely high degree of care. Alike with conventional fractionation, some tissues demonstrate recovery between treatment courses, even after SBRT, and some don't. In terms of treatment delivery, thinking through what would I want people to have as the key takeaways? Secure immobilization is absolutely essential to make sure they don't move for what can be very long treatment sessions, depending on your machinery. So, for example, where I work now, when I came into this market, they are very fixed on arc-based, essentially mostly coplanar arc-based SBRT. So it's VMAT, volumetric modulated arc therapy. And these treatments are quite short. We can get a prostate fraction done in just a few minutes. Contrast that to what I saw a lot of at UT Southwestern, 3D non-coplanar. So maybe 13 non-coplanar beams modeled out where we know these treatments are remarkably conformal. They have a nice concentric fall off in all directions, but they take a long time at the machine. We were blocking sometimes 50 minutes plus for these treatments. You got couch kicks and just even getting to the different field positions. And you want secure immobilization to make sure the patients don't move. You need accurate repositioning from simulation to treatment. So you don't have, for example, flexing of the spine, throwing off issues on pitch or yaw. You can better achieve normal tissue sparing by using, multiple, if it's 3D non-coplanar approach, so 10 or more is generally encouraged, fields, or using something like arc-based therapy, so BMAT, if you have that available. You need to rigorously account for organ motion. We'll go through a little bit of that, and I think you have some case-based training on other sessions. But as a tumor moves, you need to account for that full range of motion during your treatment. As normal tissue moves, you want to know where might it move in relation to my, planned treatment, and for how long might it be positioned there. Before cone beam CTs were readily available, they relied a lot on rigid markers of coordinates, such as on a frame or fiducial markers. Nowadays, we don't have fiducials. We don't need fiducials for most cases, at least where I'm fortunate. I have access to cone beam CT imaging for my patients. And we use that to essentially achieve the same stereotactic registration. While the original term was meant for some of these coordinate-based systems, we still use that term stereotactic with, you could argue, thousands of coordinates that a cone beam CT supplies. And this is an ablative dose delivered with sub-centimeter accuracy. We go through some of the physics on later courses. I think Ben talked about the prescriptions to low isodose lines. You can find, publications on the way in which you allow these planning systems to deliver higher, more intense hotspot inside your target and allow that benefits the software on its dose fall off outside of your target. So it's conformality. Often for SBRT, these are, has been mentioned, 60 to 80% isodose line. So you can have 40% hotspots, not uncommonly. To talk a little about the physiology and pathophysiology as applied here, it's more than just serial and parallel organs. And Sarah, I see a number of chats coming through. So, you're summarizing it for them. Thanks. All right. So it's more than just serial and parallel. You think about serial organs structured, something like spinal cord, where it is more dependent on the length of radiated and the dose to that volume, where if you cause loss of function, then everything distally loses function. Or versus parallel, something like peripheral lung, peripheral liver, kidney, where the toxicity is mostly volume related. You can destroy a small portion and patient preserves, the clinical necessary amount of function because they're structured with independent redundancy of those organs. In reality, we know that many organs are both serial and parallel. Say, for take example, lung and liver or parotid gland. You have these peripherally replicated, duplicated subsections where you can ablate small portions, but on central portions of these structures, if you destroy a key branching piece, such as branching tubular design, you can have loss of function, like a serial organ of everything downstream. So this is very important to think about when treating central lung cases or central liver cases. We think about bile ducts and what they can tolerate from SBRT, because that tends to be more of the issue there, is if you cause bile duct stenosis. There are these linear tubular designs, something like esophagus, you might think, serial, but in reality, we know that from the vasculature, you can ablate small portions, or as they do these, laser-based treatments on, say, the rectum for hemorrhoids or radiation proctitis. You can deliver extremely high amounts of, in that case, it's laser-based, but tissue injury to a small portion and have healing from adjacent stem cells or just vascular supply. And that allows us to approach clinical scenarios where a small portion may get a high max dose, but as long as we're careful about the amount spared from those potent doses, we may avoid severe toxicity longer term. And there's some just pictures there of, the example of ablating centrally on the more serial portion. You can have loss of function of, say, portion of a lobe or lobe. And esophageal sparing, this has been documented, and the clinical utility of this has been documented on trials, reported. I think there's a JAMA Oncology paper from within the last year and a half where they report on this technique and how they could deliver very high max doses to the esophagus with something like less than 5% grade 3 esophagitis long-term. When we are approaching these clinical scenarios, it might be that the standard approaches to areas at risk for microscopic disease do not apply. Some argue you're never doing regional nodal irradiation during SBRT, and it's tricky. We had a trial at UC Western treating SBRT for pancreas, and we did regional nodal coverage, which is controversial in itself, but that area got 25 gray and 5 fractions. That's not ablative, mentioned for large tumor sizes. But let's focus on lung, because this is a key concept and takeaway. Let's say a conventional fractionation of lung, which in the US, we often, do a 60 gray and 30 fractions over 6 weeks. You will contour out your gross tumor I have drawn here. I'm not saying you have to do this order. There are 2 general ways. Some will, as we nowadays, if we have 4D CT imaging available, the most, I think the AAPM endorsed method was you first do your CTV expansion, then you account for motion. Then you put your planning target volume margin. So how much extra do you want to add to your target for any issues with setup or unexpected patient motion that might occur during your treatment? This is harder to do clinically because they're asking you to expand a microscopic margin for what might exist nearby. And then they're asking you to draw out the motion of that microscopic area, which can get tricky as you're up against tissue boundaries. Most people do this. It's a gross tumor volume drawing. Then you account for the way that moved, such as what was done here was it used the maximal intensity projection image, which is the software was showing us everywhere it had moved for this specific area. So you make your internal GTV volume, then you're putting on your microscopic disease volume. And this, we often lean on surgical literature in many subsites, but when you go back to some of the pathology data for lung cancer, and you can read about, for adenocarcinomas and squames, they might vary slightly, but averaged out on the order of beyond what you see on lung window CT, often tumor cells, the little fingers, exist for about 5 millimeters around. So we do these clinical target volume expansions. We want to make sure we're capturing all those little fingers. We do that here on conventional fractionation. Then you add on your planning target volume. So what allowance do you want for errors in alignment each day? Depending on how you're going to image the patient, how you set them up, this can vary. In this example here, it was 5 millimeters. We do daily cone beam CT imaging. Now, applied to SBRT, this is a good case up against the heart I had, where you draw out, in this example, your gross tumor volume. Same. You account for motion. This one didn't really move much. You can see it moved up a little when I was looking at. I'm not showing you the MIP, the image here, but when I worked through all the phases, this is the extent at which it had moved. So I'm going to capture it. Wherever it moves, I'm going to be covering it at my target. You don't do that clinical target volume expansion. Now, one of the stories Timmerman would tell us about this was when he was first doing this, and he chose not to add on a CTV margin. His main focus was not hurting people as he sought to understand what could the body tolerate on these. He acknowledged, they understood at that time, likely there were cells in this margin around the target, but he really didn't want to hurt patients. And so the earlier trials were done without CTV margins. They were done with large enough PTV margins that we know that from this expansion and from normal dose fall off, we were getting coverage of that microscopic disease. So if you back, they did often 5 millimeters all around or 1 cm and with 1 cm sup inf. You're getting that 5 millimeters from your planning target volume, prescribed dose. And that is the point where you're seeking your prescription dose. Well, as it falls away from the physical limitations of dose, you're getting some medium-high doses for an extra few millimeters that he believed was covering that microscopic disease, and it worked out. We see wonderful local control rates. The point is, I came into this market and you have new adopters learning about SBRT, and they'll say, can I do a 1 millimeter margin on this site? I line it up perfectly every day. I'm not worried. And I say, no, you don't want to deviate from how we developed our understanding of what's needed for this tumor control. We don't move to a 1 millimeter PTV margin because then in this lung example, because that's serving two purposes for lung. It is our alignment issues and it is covering some of our microscopic disease. I hope that makes sense. So don't push the limits too much on something like lung here. Allow your PTV to be at least 5 millimeters in each direction. So that's kind of the no CTV margin in lung takeaway. You have to consider all adjacent normal tissues at risk. So you look at this case I had previously last fall. You might say S3 down to the coccyx. Who might have an idea about organs at risk here we need to be aware of? Any volunteers? Just give it a few seconds to see if anyone responds in the chat, or I'll steal the thunder. Sorry, phrase use here. Rectum, yeah. But don't forget something like if you're down the pelvis, lumbosacral plexus. You'll find constraints listed for brachial plexus when you're up in the shoulder, lumbosacral plexus down in the pelvis. Paul Medine, I'll mention later about spinal cord literature, but a medical physicist at UT Southwestern has made his career over nerve tolerance to SBRT. He really believes that the peripheral nerves in general respond the same to these doses, and you can use the same constraints applied. But don't forget about things like the sciatic nerve, the sciatic nerves, femoral nerves, where you're treating sacral plexus. You want to be aware of where they might be, depending on your degree of comfort level. I had an MRI in this case. I could see it very clearly. You can define these and be careful of where you're putting your hot spots or where you're distributing your dose. Would you think motion management would be needed in this case? In terms of, is it going to move naturally? No. With a good secure setup, it's not like a lung tumor where you have to create an internal target volume and ITV margin. And PTV margin here, it depends. So one of the schools of thought I was trained under, Timmerman had observed some marginal failures in bone for bone mets, where he had later on adopted a 5 millimeter CTV margin in bone, which is seen here in blue, because, and depending on as well, often you'll get an MRI, treatment planning if you have it available, and it will show you disease beyond what is on CT. If you don't have it available, that's okay. I encourage something like a bone metastasis. You add a little CTV margin in the bone in case there is some microscopic disease there. As you know, he taught me, you're not adding it out into soft tissue, say here in the mesorectum. PTV margin, secure setup. Patient's not going to move if they're compliant. We monitor them with that surface monitoring software I mentioned. So this is just 3 millimeters PTV margin. I felt comfortable that we could keep it within there. About this node, porta hepatis node, when I came to the center, if you have 4D CT imaging, what you may have in your software is the ability to compute an average scan, which shows you the average position of where everything is in time. That's better for planning if you're able to take a large enough scan. This is what's shown a free breathing scan, so a quick acquisition CT scan. The node on that quick acquisition just happened to be here. When we used 4D CT imaging to account for where does it move as the patient breathes, the diaphragm rises and falls, the extent of motion is in blue. PTV margin here, I was tight. We had a good setup. I felt like with cone beam, I'd be able to see it and be very careful. And I was worried about central bile ducts. That's OAR to consider here. And so I used 3 millimeters. I would have used a little more if I could have, or if I felt comfortable, I wanted to be as careful as possible. This was an oligometastatic lung case. She was treated definitively. It'd been about a year. This showed up avid on PET CT. They thought too risky to biopsy. It was, SUV of 9. It was very radiographically consistent with disease. We treated her. She's now out another 1.5 years with no evidence of disease. So the motion management piece, some may apply abdominal compression. I'm sure you'll hear about during the following sessions. So it's pressure applied on the abdomen to try to prevent the diaphragm from moving up and down. And there are different bridging pieces of equipment that might allow you to push pressure on the abdomen and hold it to prevent the diaphragm and limit the degree of motion. Breath hold, I'll mention, I'm sure it'll come up in a future session, but I'll throw one of my soapboxes in there. Use caution when treating with breath hold, depending on what kind of equipment you have. And if you're going to do it, take at least 3 breath hold scans. There's literature published as to how many do you need to establish consistency to account for the variation in breath hold. So take at least 3 if you're going to do it. But I don't use breath hold for SBRT hardly ever. PTV margin we talked about. This is the commonly accepted way you contour the central hepatobiliary tree. If you look at liver SBRT literature, there have been cases reported of bile duct stenosis and fatal hepatitis resulting. Thankfully, it's a reasonably radio-resistant structure. You contour portal vein, you expand, you think you're catching all bile ducts, common, hepatic duct, again, cystic duct, in this expansion. And she had, I can't remember if this is the one. Also watch out for if they had if their gallbladder was previously moved, they might form this neo gallbladder of the common bile duct where it enlarges, almost serving as functionally a gallbladder. And that might look different on your scan. I've seen that. That's very interesting variation. This was 40 gray and 5 fractions. So 8 gray times 5 fractions. There are constraints for the hepatobiliary tree that were respected here in the table. Just things to be aware about that you might not think about during conventional fractionation. It's not as commonly a worry. This was another oligometastatic patient. So we were taking a little more risk in delivering this ablative treatment because this was the only known site of metastasis this patient had. Contoured, gross disease, as seen on my T and MRI that I had for this case. Put a CTV margin around it, as I talked about, for bone. That's my style, was trained for bone. And a small PTV of 3 millimeters. I felt like I'd be able to keep them still. What OARs might you consider? Of course, bowel, rectum. We're away from sciatic nerve, but if you're closer, you might consider contouring out the nerve and trying to limit max dose there. I don't have a constraint for acetabulum right now that I'm aware of. Look at this on the way of, this is another 40 gray and 5 fractions, and you can see the hotspot, of about 25%. But it allows for more conformality. And as I was trained, you're not worried about hotspots inside tumor. And 50 gray and 5 fractions on bone, it can take it. So there's pictures there. I was asked to speak on some on spinal cord. I'm not here to push, everyone start doing spinal cord reirradiation by any means. That's, I think, one of the much riskier clinical scenarios, even riskier than reirradiation for brain metastases, which, if it's peripheral, you can reirradiate. If you cause radionecrosis in the brain, you may have a surgical salvage option. Spine, we don't have it. But I want to go through some of our understanding of spinal cord tolerance from these high dose per treatment styles. The volume receiving dose can dramatically change the tolerance. A lot of this is from animals. I mentioned, it's not ethical to perform these experiments of tolerance in humans. But from this paper in early 2000s, you saw as you change the volume of cord exposed, then your estimated dose for 50%, chance of loss of function of what dramatically changed. All of a sudden you went from, if 2 millimeters in rats, your ED50 of 88 gray became only 20 gray with a larger volume treated. Palmadine, I mentioned before, who's focused a lot on spinal cord and peripheral nerve tolerance to SBRT. They call him the pig maestro. He uses pigs for a lot of his trials, which I gather is a great model of the human spinal cord on the way it's structured, on the way it responds to radiation. In one of his more famous papers, they took pigs and they treated them up front with their first treatment course to learn what could the spinal cord tolerate in the first so-called de novo treatment. And they plotted out this tolerance in treating kind of a target planned laterally. So they were trying to just kind of kiss the spinal cord with the 90 gray isodose line, have it 50% midway through and 10% just at the kind of the opposite edge. On this particular study, it took about 30 pigs. They gave them 3 gray times 10, a very common pi. And then they waited a year and they retreated because he had sensed from other prior work that the spinal cord was demonstrating recovery over time. Now look at this. The first treatment course and tolerance, this sigmoidal response curve that we think about for a lot of tissues. So blue, first treatment, ED50, maybe 20 gray, exactly like the rats and other animals have consistently demonstrated about this. On the retreats 1 year later, after 30 gray and 10, it was nearly identical. Thought that it, on pigs, nearly completely forgot the prior dose and behaved clinically as though it had not been treated before at the ED50 of 19.7. That was fascinating. More recently, a group of specialists in this area got together and they looped in that from the prior study. And they called this high-tech organ-specific paper on the spinal cord that came out in 2019, which I encourage you to read. They acknowledged that some preclinical data, so in animals, and limited clinical data in humans, suggests there is a partial recovery as time prolongs, but the extent was very controversial. They went in the tables in their talk and they mentioned some of these prior papers and what constraints they endorsed. The first author on the paper really pushed his own from 2013, which was the more conservative, I think a safer approach for the authors to take over what they endorsed as a constraint depending on number of fractions. In the reirradiation, they gave these recommendations. They said, if you're using that equivalence dose formula that mentioned that was the same as BED formula, just using the number 2 for dose per fraction. They wanted the cumulative thecal sac. They said contour the whole thecal sac as your cord just to be safe and calculate that as if it's the spinal cord. Don't let that exceed 70 gray. On the reirradiation episode, don't exceed 25 ever on the equivalent dose to 2 gray per fraction. They didn't want the ratio to be high. I think that is so soft, but they mentioned that recommendation. And the minimal time interval of at least 5 months, because there are papers out, from repeating palliative treatments, which I'm sure you all face as well. We do here for sure. Repeating 8 gray times 1, 20 gray and 5 fractions, 30 gray and 10. There's some conventional fractionation literature that cord recovery seems to be at 6 months setting in. And they wrote 5 months here, which they felt justified. Interestingly, they point out, they take this political safe line of there's no validated means for counting between the time between courses and the amount of recovery. It's controversial. So go back to those learning objectives as to describe current understanding and limitations of some of our radiobiology of hyperfractionation to a colleague, to retell some of the principles of normal tissue toxicity, depending on its alpha beta, how it might respond to doses of a certain size, and then spinal cord recovery, resources to approach uncertain situations. That's turning to the literature, the clinical trials, what published outcomes data do they have, normal tissue constraints data do they endorse, and then treatment decisions for irradiation comfortably. That's why I include those recommendations, but that is a riskier scenario, so proceed with caution. Sure. Some references and resources are included at the end of this. More listed there.